Good morning. Let's go ahead and get underway. Welcome to Grand Rounds this morning, where we're going to be recognizing one of our former faculty members by the naming of the award, and one of our assistant professors and the recipient of the award. The award that we're presenting this morning is named after Phil and Helen Fialco. Phil was a native of New York, came here as a resident, went on to a medical genetics fellowship with Arnold Maltulski in our division of medical genetics, became an expert on the cellular origin of neoplasia, particularly malignancies and benign hematologic disease, rose through the faculty ranks, became the medicine service chief at the VA and vice chair of the department, and then moved to become the chair of the department for about 10 years, and then became dean of the School of Medicine. And throughout his career was interested in supporting the scholarship of trainees and junior faculty. Hence, it was felt to be appropriate to name this award for an assistant professor after Phil and Helen. They, during the time that he was dean, were tragically lost and killed in an early snowfall during a trek in Nepal. And so this award was set up in their memory. As it states, support of a junior faculty member who shows outstanding promise as a scholar, an area that he supported throughout his very distinguished career. So I would now turn it over for the introduction of the assistant professor, who's picked actually by a committee of about 6 or 8 of our excellent faculty. Each year have the difficult task of reviewing a substantial number of assistant professors who are proposed by their divisions for consideration for the award. This year it's in the Medical Oncology division, and Mark Stewart, who's a professor in that division, is the medical director of the Cancer Care Alliance and is the acting division head in medical oncology, is going to introduce the awardee. These are the former winners of this award over the years since it was established in the late 90s. And to jump ahead and steal your thunder, I'll show who the awardee is this year, and then Mark can go ahead with the introduction.
Thank you, Bill. You know, it's a great pleasure to introduce Dr. Mohamed Sorror. Mohamed, of course, is a very deserving candidate for this award, as you'll see over the next 45 minutes. Just to tell you a little bit about Mohamed, he began his medical training in Egypt at a number of different centers before moving to Seattle in the mid-2000s, where he did a postdoctoral fellowship at the Hutch, and also did his oncology fellowship here at the Hutch and UW. In 2010, he joined the faculty as an assistant professor. In his relatively brief time as a faculty member, he's published almost 70 different publications in journals with high impact factors. He's been first author on about 20 of those, and he's done about 60 national and international presentations with oral presentations in about 20 of those also. He has outstanding funding from the NIH, PCORI grant, American Cancer Society funding, and some industry funding for his work. To talk a little bit about his work, or to set the stage, some of you know that stem cell transplantation is fraught with some morbidity and risks. Happily, over the last 2 decades, largely through efforts by investigators at the Hutch, we've actually been able to improve survival and decrease morbidity with this procedure. One of the procedures, using a less intense conditioning regimen, has actually allowed us to use blood and marrow transplantation for patients who were in their 60s and 70s. And this was unheard of probably a decade and a half ago. As we increase the eligibility, particularly related to age, that means that we need to assess some of the comorbidities that go with that, whether that relates to higher risks of heart disease, lung disease, kidney disease, depression, diabetes, etc. And so Dr. Sorror has really focused largely on developing an index that takes those comorbidities into account and gives us a predictive model for outcomes following stem cell transplantation. This has been an extensive series of studies that he's done, and the work is quite good. His work, though, of course, isn't finished at this particular point. His career is just launching, and he has a number of other questions, I think, to answer, happily. He has more work to do. So will his indices be reproducible at other centers? And what will be the necessity of changing the measures that he uses as we continue to make improvements in treatment? How will the index predict for quality of life? And can we use the index to select the right kind of conditioning treatment? So all of these things are important for physicians to know so that they can recommend the best treatment, but most important for patients to help them understand their prognosis and the potential risks. So congratulations to Dr. Sorror.
Well, thank you very much, Dr. Stewart, for this amazing introduction. This is my disclosure slide. And I'm speaking today about allogeneic transplant in older and medically infirm patients. As many of you know, the outcome of patient was, most of the blood cancers could be quite poor. For example, patient with acute myeloid leukemia who don't achieve complete remission under first induction, they can suffer from poor survival. And even with some indolent diseases such as chronic lymphocytic leukemia, they have some chromosomal operations that carry high risk, for example, deletion 17B, they could still have poor prognosis after conventional therapies. But the problem is actually more pronounced if you look at people who are older, 60 or above. Here is a study by Dr. Fred Applebaum from the department where he's showing clearly that even for people who have favorable intermediate or high-risk cytogenetics, people who are 60 or 60 above consistently do poorly with conventional therapy. And probably it kind of assigns both intolerance to treatment, but also maybe a reluctance of physician to give them the adequate doses of treatment for fear of toxicity. And in this study, the health status was captured by a cog performance status. And it could also show, in addition to age, the worsening of the performance status result in poor survival of these patients. Allogeneic hematopoietic cell transplantation could offer potential cure for many blood diseases. And as many of you would know, historically, the allogeneic transplant was designed in a way to give high-dose conditioning, a form of chemotherapy plus or minus radiation that would result in some tissue damage, inflammation, and release of antigens that would be presented to the coming donor T cells that would result in activation, proliferation, and then under the laws of the major histocompatibility and minor histocompatibility differences between the donor and the host, those effector T cells will attack the tumor, resulting in graft versus tumor effect, which we rely on in eradicating the remaining of the malignancy and also preventing it from coming back. But also it has a harmful effect on many of the tissues, skin, GI, liver, and even the hematopoietic system itself, resulting in what's called acute graft versus host disease, which together with infection and organ failure are the major complication after transplant. Dr. Deegan Sanmire from the department summarized the evolution of the conditioning regimen over the years. Over the past 15 years, here in Seattle and many other sites, there was development of novel conditioning regimen that more reduce the intensity of these regimens with the hope to allow it to different types of patients and reducing the toxicity. So we started here high with the higher intensity conditioning regimen, and you can see here in the middle what we would label as the reduced intensity, where They might ablate the bone marrow from the hematopoietic system, but still result in less amount of toxicity. Down here to the 2-gray total body radiation that was developed here in Seattle by Rainer Storb and his colleagues, that's considered non-myeloblative. It will not ablate the bone marrow. Rather, it depends on immunosuppression in order to allow the donor graft to settle in. The point from this figure is, as the conditioning intensity goes down, the toxicity should go down, but also the reliance on the graft versus tumor effect and success of the transplant becomes higher because you don't have the ablative effect of the high conditioning intensity. I want to add to this figure the idea that as the intensity goes down, the age of the patient that offered this type of transplant and their health status are getting worse. They are older and they are more comorbid. So even you would expect less toxicity with less conditioning regimen, but the patients you're offering this treatment to start with are not the same type of treatment that we used to treat with the high-dose conditioning. So some thoughts needs to be done in understanding how these patients could be treated with allogeneic transplant, even if it's with reduced intensity. And that's what I focus most of my work on years. And I try to address a couple of major points. One of them is how to advance the biomedical knowledge in order to make accurate decision-making for decision about treatment of these types of patients. And I will focus most of my talk on this aim. But the other one is how to come up with clinical trials that can focus on certain types of these blood cancers and with the aim of improving survival, but not really on the expense of their quality of life. So decision-making is not an easy process when it comes to allogeneic transplant. I saw a consult at the beginning of this year, a 79-year-old male who worked as a physician all his life, and he came with acute myeloid leukemia in second complete remission. His disease relapsed after 18 months of first remission. His past medical history was only significant of melanoma that was resected locally in 1977. He was fully active. He can take care of his activities of daily living. He was married and accompanied by his wife, indicating reasonable social support. And he has an available HLA identical sibling. When you ask him about his preference for treatment, whether it's longer years of life or quality of life, he was clear. He wanted cure of his leukemia. And then you come to the question how to treat this patient. Should you offer him high-dose conditioning, myeloblative transplant, in order to try to eradicate and cure his leukemia? Should we give him additional conventional chemotherapy and watching him closely? Should we refer him to palliative care? Should we give him, under certain circumstances, reduced intensity conditioning and followed by allogeneic transplant, or should we offer him hospice care? And as I said, allogeneic transplant can be potentially curative therapy for many blood diseases, but it is actually the most complicated procedure in medicine, where the success of the transplant rely on the interaction of multiple different factors. Some of them are transplant-related, such as the intensity of the conditioning, the type of donor. Others are disease-related, like the diagnosis and the disease features, chromosomal operations, etc. And all these factors have a lot of focus in trying to understand how they impact the success of transplant. But other important points would be the patient-related factors. The easiest one would be age, but the more detailed one would be the complexity of their health status. So I started my career by doing a study under the mentorship of Dr. Rainer Storb. And we had a simple question. We wanted to know, since the introduction of a reduced intensity or non-myeloblative conditioning, how the outcome of people who receive the high-dose conditioning compared to those with non-myeloblative conditioning, specifically when they receive the HLA-matched unrelated donor grafts. And we were focusing on toxicities, acute graft-versus-host disease, and non-relapse mortality. Not surprisingly, when you look at the baseline characteristics of these patients, that there was huge differences. We tend to give the mini-transplant to older patients. Sometimes they receive way more pre-transplant therapies in order to get the transplant. And of course, they are selected for the mini-transplant because we think they cannot tolerate the higher dose conditioning. So really huge differences between the two groups. But if you want to really advance the knowledge, you feel like there's something missing here, is how to capture the difference in health status between these two patients, or what we would define as comorbidities, all the medical problems in addition to their primary cancer that might play a role in the prognosis and the result of their treatment. Particularly that in the field of cancer and also in the field of medicine in general, comorbidities have played a great role in determining the outcome of multiple different treatment approaches. So we started in our study by using a well-known comorbidity index called the Charlson Index that was developed and then validated in a group of patients with breast cancer. And when we applied it in our cohort of patients, as I said, unrelated donor recipients, trying to compare both conditioning regimen, we came up with two major points here, or take-home messages. One of them is this type of index can clearly classify the risks of non-relapse and overall mortality within each conditioning intensity. But also, most importantly, it can help us in comparing the outcome of patients, let's say, those who have no comorbidities or score 0, between receiving non-myeloablative and high-dose conditioning and how the difference in outcome looks like. And we published this data in Blood of 2004, but then it was clear when doing the study that you could see that there were some limitations in using this type of index in our cohort of transplant patients. For example, some of the comorbidities were rarely identified. For example, pulmonary and hepatic comorbidities, because the definitions were not so sensitive. Some other comorbidities that we see frequently in our patient population, like infection from repeated conventional therapy or psychiatric disturbances, which is quite common, are not represented at all in this index. So you end up with some degree of lack of sensitivity. This index captured only 1/3 of the patient, if any, with comorbidities. And if you look at people who receive high-dose conditioning, the percentage was 12%. And you have to stop here and ask, is it true that almost 90% of the patients that we see in the clinic and give high-dose conditioning are completely healthy except of their primary cancer? Probably it's not true. It's probably a defect in the index itself. And up to that point, there has no data in the transplant field to look at multiple comorbidities in regards to their prevalence, how they interact with each other and affect transplant outcome. How can we combine them with other known traditional risk factors to help in risk stratifying patients before moving to transplant? And it became clear that time has come that this has to be addressed, because with the aging of the population and those older patients are the ones picking up comorbidities, and also they constitute the majority of people with new diagnosis of blood cancer. Now with the non-myeloablative reduced intensity regimen, we're seeing more and more of these patients coming for asking for a consult to see a transplant. So a game changer here decided to take the burden of developing a new index that's suited specifically for people who receive allogeneic transplant. And we did that by collecting data from a large sample of patients, about 1,000 or more, that were really well represented of all types of transplant strategies in regard to conditioning intensity, graft type, and different diagnoses. We split the sample randomly into two groups, one called training set, where we will study the association of comorbidities with our outcome of interest, and then the other group we will try to validate our findings. I started with the Charlson Index as a backbone of the study, but then did some major changes. One of them is I wasn't governed by the comorbidity definition within this index, and instead collected all data from our patient population in order to understand how they impact outcome of transplant. But also try to modify the definition of some of the comorbidities within the Charlson Index, making them a little bit more sensitive by adding laboratory values and organ function tests. Most importantly, calculate new hazard ratios to see the association between each of these comorbidities and non-relapse mortality, which is, again, the outcome of interest for this cohort of patients. Here is an example. If you look at the Charlson Index, they define pulmonary comorbidity based on different grades of shortness of breath. What we've done here is adding diffusion capacity of carbon monoxide or forced expiratory volume in 1 second as two parameters to help capture the impairment in lung function. And we didn't have much of information where to start from in regards to cutoffs. So what I did, I used the same cutoffs that were implied by the common toxicity criteria of the National Cancer Institute in assessing patient toxicities after conventional therapy. The same with hepatic comorbidity, in addition of cirrhosis and portal hypertension, which I would say almost rarely we see in our transplant patients, and instead use values of bilirubin and transaminases at, again, the same cutoffs in the CTC criteria. So we ended up with a total of 28 different definitions of comorbidities that were found on those large group of transplant patients. And then with the help of a great statistician and a collaborator, Dr. Barry Storer, we developed these regression models looking at the outcome, non-relapse mortality, after adjusting for traditional factors such as diagnosis, conditioning, age, but also the impact of each other comorbidity, because we wanted to make sure we capture the independent association with outcome. We use the product of these models, hazard ratio, at a certain cutoffs to convert them into simple weights that can be calculated as a total score. So from the 28 comorbidities, we ended up with 17 that met the criteria of hazard ratio above 1.2. And according to the increase in the hazard ratio, as you can see here, they were assigned different weights with the whole idea of calculating the total score at the end. One of the major changes that we've done is we have shown that depression and anxiety, morbid obesity, and infection can have an impact in increasing non-relapse mortality in this cohort of patients. So they were added to the model compared to the Charlson index. We increased the sensitivity of the renal, pulmonary, and hepatic comorbidity by adding laboratory values. So you can see their prevalence have increased compared to what we've seen before if you use a Charlson index. We ended up with this type of one-page sheet that summarized what we call the hematopoietic cell transplant comorbidity index and a slight definition of each of these comorbidities and then the scores that can be summated in a total score for each patient. And then in the validation set, as you can see here, we calculated the score using two indices in this group. The HCT-CI, you can see it can divide patient nicely with equal distribution at the different comorbidity risks, and then can stratify the risks of non-relapse mortality. While the CCI has the same anomaly I mentioned earlier, that most of the patients are actually squeezed and having no comorbidities. And because of that, and because probably for other reasons, it wasn't robust enough in stratifying risk of non-relapse mortality. We used a concordance probability estimate as a way to assess the performance of models. For example, c-statistic estimate, which for a binary outcome will be similar when you do an area under the curve analysis. And 0.5 means no prediction, 1 means perfect prediction. You can see that the HCT-CI had higher c-statistic estimate compared to the Charlson index that was highly statistically significant. We published this data in Blood of 2005 that was welcomed by a nice editorial in the same journal in the same year. But then in order to take this forward, in order to really advance knowledge how we handle our patients, our medically infirm patient in the clinic, we needed to have some kind of a roadmap or some aims that we try to assess. And I was fortunate to be funded by a grant from the NHLBI, of the National Institute of Health. I'll touch a little bit on each of these aims. The first one is how to use this index in comparing the effectiveness of different conditioning intensity and transplant strategies that can help us in the clinic. I'm giving here one example of these studies. Here we focused on patients who receive allogeneic transplant, who have a diagnosis of lymphoma or chronic lymphocytic leukemia. And then we look at patients who have no comorbidities or a score of 0, comparing high dose versus non-myeloablative conditioning, and adding a product of regression model in the figure which adjust these two groups to the difference in pre-transplant variables, trying to see if we take into account the other variables, how the outcomes will look like. So the take-home message from here is if patients have no comorbidities, the non-relapse mortality was similar whether they received the high dose or non-myeloablative conditioning. In fact, it was less than 20%, and that figure is unheard of for people with lymphoma CLL receiving high-dose allogeneic transplant. So it really signifies that we can identify a group of patients that can benefit from the high-dose conditioning. And where you take this information to, you can offer high-dose conditioning for people with rapidly progressive disease, but you can also use this information in designing prospective randomized studies between the two conditioning intensities. But if you look at patients who have comorbid score 1 or more, it was clear that the non-relapse mortality was almost double after high-dose conditioning compared to the non-myeloablative transplant. And if you adjust for the difference between these two groups, the idea that high-dose recipients are usually younger, etc., then the difference becomes even wider between these two groups and showing a survival benefit if you give non-myeloablative conditioning. So you use this information in the clinic when seeing patients who have multiple comorbidities but have a diagnosis of lymphoma and CLL, and recommending non-myeloablative conditioning transplant as an approach probably with a better survival benefit. I wanted also to standardize the comorbidity assessment, not only in the US, but also across the globe. And in order to do that, you have to address two major items. One of them is showing that this index is valid at different other institutions, but also trying to make sure that it is reliable. It can be reproduced similarly at different institutions. There's a number of validation studies. I'm showing one of them here. This one was done in collaboration with the Center of International Blood and Marrow Transplant Research, which is the large registry database that collects data from all transplant centers across the U.S., worked with them closely to incorporate this index in their routine collection of data from all transplant patients across the U.S., and then proposed, since we're doing this huge effort, is to design a prospective study where we collect this data prospectively and then try to validate that this index can really predict outcome of allotransplant, as well as see if we can reproduce the results in people who receive a different type of transplant, autologous transplant, again, for malignant diseases. Over 2 years, we collected data from a large sample of patients, 23,000, and that ended up with a nice 8,000 patients receiving allotransplant and 11,000 receiving autologous transplant. Similar to what we found in our initial studies, as you can see here, this is a product of regression model. As the scores, 1 to 2, 3 or more of the comorbid scores goes higher, the hazard ratio, as presented here in the box plots, goes higher for non-relapse mortality as well as for overall survival. And that was statistically significant. This was for allogeneic transplant. Similarly, for people who received autologous transplant, the increase in each of these scores resulted in higher hazard ratio for overall mortality. The other point that I addressed, again, as I said, reliability of the index. And the way I did this is using a sample of patients and then asking 3 or 4 different investigators to evaluate comorbidity in the same group of patients and trying to see how much they agree on these scores. And most of these evaluators did not have previous experience in assigning comorbidity weights. In fact, many of them were visiting physicians. And then we used a statistical test that can measure inter-rater reliability, weighted kappa, that takes into account agreement that could be just by chance, but also it focused on how the disagreement between evaluators result in shift of a patient from one comorbidity risk group to the other. And we found that the maximum that we could achieve is 0.58, where 0 is no agreement at all and 1 is perfect agreement. So that actually put the index at a rate what we would describe as fair to moderate rate of agreement. Did similar study with CRB-MTR using data from other sites, Dana-Farber and Roswell Park, and we have almost the same results. So I went through this effort trying to develop a brief training program that can guide new investigators how to evaluate comorbidities. Started by putting down some consistent methods, how to go to the medical records and acquire the data that would be enough to complete the comorbidity evaluation. Not only efficiently, but also in a short time, because we don't want to consume a lot of time doing this type of evaluation. So following these steps, when validated, it takes about 15 to 20 minutes for each patient. And then develop some language, some guidelines under each definition of these comorbidities, trying to give some guidelines when to score a comorbidity and when not. And supplemented this with a calculator, web-based calculator, where people can enter raw data, and then it calculates the scores for each patient. And then I published this in Blood of 2013, and this brief training program, couple of pages, give it to new evaluators, asked them to evaluate a new group of patients to validate that it can work. And here is an example, as I said earlier, of the weighted kappa, where 0 is poor agreement, 1 is perfect. I put here some example of comorbidity indices in the field. Usually the agreement rates lies between 0.65 to 0.8. When we did this effort of the training program for HCT-CI, we could show in 4 different evaluators that the agreement was 0.9 to above, the highest was 0.97. Then after we established the index as a tool for health measure assessment in different sites, it was important to ask the question, what role is remaining for age when we decide about transplant? So I did 2 different studies. The first one focused on people who received non-myeloablative allogeneic transplant that I mentioned earlier. Here I'm describing the regimen that was developed by Rainer Storb here in Seattle and his colleagues, giving 2 grade total body radiation in addition to 3 doses of fludarabine that can ensure immunosuppression that would be enough for the donor cells to settle in a mixed chimerism fashion with the host T cells until they take over later on after we taper off the immunosuppressive medication, which is mostly a calcineurin inhibitor like cyclosporin combined with mycophenolate mofetil for an average of about 1 to 6 months. I also worked closely with Dr. Brenda Sandmeyer, who is the PI in many of these protocols. Here we focused on the outcome of this mini transplant in people who are 60 years or above. And this type of analysis hasn't been done before. And we used data from multiple sites and patients who were enrolled in clinical trial and published the data in JAMA of 2011. Here you can say the breakdown of some of these patients. Some of them were above 70. Take-home message was, in those older patients who have advanced blood cancers receiving allogeneic transplant, 1/3 of them survived at 5 years after the transplant. And from those 1/3 of patients, 2/3 of them came off all immunosuppressive medications, and their performance status of the last check, the median was 90%, indicating a recovery from the side effects of the transplant. But the other important message that came from this study was age per se, whether used as categorical or continuous variable, had no impact at all on non-relapse mortality, on graft-versus-host disease, and survival. But the health status, as measured by the Comorbidity Index, predicted most of these outcomes. In fact, in a regression model, the two factors that came as most important are the comorbidities as a measure of health status and the disease status at time of transplant, which gives you an idea about risk of relapse. And when you couple these two factors together, we could stratify patients into 9 different categories, where, for example, if people had no comorbidities and they are acute myeloid leukemia and first remission, they could have 5-year survival as high as 70%. If they have multiple comorbidities and higher disease risk, for example, lymphoma and relapse, then this figure can go down to 20-25%. So this type of stratification is very helpful in the clinic in deciding to proceed with transplant or not, but also in comparing transplant versus non-transplant approaches. The other study that I did to define the role of age, here we decided to expand my scope a little bit. So instead of 60 or above, start from pediatric up to 75 to really define the role of age, if any. But also look at all types of conditioning regimen intensity, because we wanted to have some kind of a landmark how to choose between those conditioning regimens for people of different ages. And we had here a large sample of patients from multiple sites, 3,000. So we did multiple tests. I'm showing one example here where we split the group into a training set to define the role of age, and we found that up to age 39, age per se had no impact on non-relapse mortality. Once reached age 40 or above, there was higher risk for non-relapse mortality that was statistically significant. But the important thing is when we compared these two groups to each other, they were not statistically different, suggesting that really the cutoff was 40 or above. And used the same equation that we used before to develop the Comorbidity Index, where we assign weights based on the hazard ratio cutoff. We ended up giving a score of 1 to any patient who have an age of 40 or above. And then validated these findings in a different set, where we can see that it's true that people who are 40 years or above have some increase, not a lot, but some increase in non-relapse mortality that was consistent whether they receive high dose, reduced intensity, or even non-myeloablative conditioning regimen. We then incorporated age as a score of 1, combined it to the other 17 comorbidities to calculate a total score. And using the c-statistic estimate, you can see that this composite score has slightly better performance than the Comorbidity Index alone, but hugely better than age alone. So basically what we've done is we use the HCT-CI and add age 40 or above with a score of 1. So the take-home message here is age has some effect, but it's minimal. And that's important because it can show the often small effect of age in comparison to the health status, which is an important consideration because for many years, our decision on our pre-transplant assessment has been mostly biased against people who are above 60. So this is a better way into looking at patients. Here is, I'm giving you an example. Patient 32-year-old, she's a woman, she has myeloid malignancy. She was given HLA identical allogeneic transplant using high-dose conditioning, busulfan and Cytoxan. The same year, almost the same month, a 62-year-old man with myeloid malignancy was given the same exact type of transplant, allogeneic transplant from a matched sibling using high-dose busulfan Cytoxan. When you look at this, she's quite younger than the 62-year-old, but if you look at her comorbidity and age score, she had a score of 8 because of pulmonary, hepatic comorbidities in addition to prior malignancy. While the 62-year-old had only a score of 1 for being above 40 years of age. This patient died 6 weeks after transplant for multiple organ failure, and this patient survived for 6 years after the allogeneic transplant. So really what we're trying to do here, what we've done, we published this data in GCO of this year, and we're trying to change the practice across the institution. Instead of when seeing patients, govern them by their age groups, calculate their comorbidity scores, and redefine the risk, in addition to combine them with the disease feature and the transplant risk factor and the final decision making. So you really can achieve what you would hope for when seeing a patient in the clinic. You can play with the numbers and change their age and put them in a different category. And then we wanted also to understand how comorbidities impact non-relapse mortality. What are the associations with different outcomes? Not surprisingly, in one study, we shown that people who have multiple comorbidities before transplant are the ones who are in 2 to 3 folds higher dying from organ failure after the allogeneic transplant. But interestingly, in a collaboration with another great biostatistician, Dr. Ted Gooley of the Clinical Research Division, we have shown that those comorbidity scores that we assess before the transplant, it can give us a good estimate of risks of a complication like acute graft versus host disease. In fact, the incidence was almost double compared to people with no comorbidities. And we asked the question, well, which one of these 17 comorbidities that could be associated with a specific toxicity like this? And we found in a regression model that few of them specifically had a higher hazard ratio for prediction of acute graft versus host disease. We're trying to understand this a little bit more, and one hypothesis that we're trying to follow is what had been published by other investigators before, that the increase in certain cytokine levels after transplant, usually done at day 7 after transplant, is associated with higher risk of acute GVHD. Things like soluble IL-2, receptor alpha IL-18, TNF-alpha, hepatocyte growth factor. These cytokines were found to be associated with higher risk of GVHD. But many of these cytokines also are implicated in the pathogenesis of some of these comorbidities. And our hypothesis is if we check these cytokines before transplant, maybe it can give us a good guidance into which patient can develop acute graft versus host disease, but can give us also a tool in how to approach managing some of these patients with comorbidities. But not only that, we found that those pre-transplant comorbidity scores, once the patient developed graft versus host disease, it can give us a clear understanding of their prognosis after that, as you can see here in the stratification of survival after grade 2 and grade 3 to 4 GVHD. And these data can be quite helpful in deciding whether to proceed with treatment of acute graft versus host disease or not, which is usually intensive in giving steroids as immunosuppressive medication, but also can help us in proposing for certain group of patients that can tolerate novel approaches where we can intensify the treatment of graft versus host disease in comparison with the standard treatment. We also continue to work in improving the objectivity and predictivity of this index by testing new biomarkers. We're interested in things like serum albumin as a measure of nutritional status before transplant, and also included in some well-known prognostic score like the Apache score, for example. Serum ferritin as a measure of inflammatory status, but also could be reflective of iron overload. And platelet count that can give us an idea about the marrow reserve after receiving some multiple chemotherapy regimens. We found in multiple tests that decreasing albumin values, higher ferritin, and low platelet count, each one predict non-relapse mortality in addition to the comorbidities in the HCT-CI. And then did similar tests in assigning weights to these comorbidities and add them to the HCT-CI and could show that really the predictivity here, the area under the curve figure, can improve of this index if we add additional biomarkers. So in summary of this part of my talk, we were able to develop a transplant-specific comorbidity index. We've shown that it's valid at different institutions. We've done some work to improve the reliability to an excellent degree, and it can provide important, valuable prognostic information that in combination with disease feature can guide the decision-making in transplant, and it was designed in a simple fashion that can help adding other objective biomarkers. We resolved the issue, where should we look at when we see patients with different age groups? We define that the calendar age has a minor role in outcomes, and people should only evaluate transplant candidates based on the combined comorbidity and age weights. I'll touch base on some of the clinical trials that are trying to improve survival on these cohort of patients. I was interested in a disease, chronic lymphocytic leukemia, in particular patients who are refractory to fludarabine, which has been shown before to have a poor survival when given conventional therapy. In cooperation with another great investigator, Dr. David Maloney of the department, we could show in a clinical trial using the non-myeloablative allogeneic transplant that those high-risk patients could achieve a very nice survival of 60 to 70%. But most importantly, too, we showed that these patients mostly achieved cure of their CLL because when judging by molecular response, they had, most of them had molecular remission of their disease. that lasted for 6 to 7 years after transplant. But also take-home message from these studies were that the graft versus tumor effect is a slow process. It takes few months to eradicate the disease from the different levels of cytogenetic bone marrow lymph node molecular response. But also, it's more robust if people receive unrelated donor grafts. It happens a little bit quicker, probably signifying the wider differences in the minor histocompatibility antigen between an unrelated donor and a host tissue. But the interesting thing is most of the relapses or progression that happened in these cases happened in this time interval where the graft versus tumor effect was trying to kick in and deal with the CLL. So what I'm doing now for these types of studies, we're coupling the non-myeloablative conditioning with the CD20 monoclonal antibody with the hypothesis that in addition to direct cell kill, these types of antibodies, by inducing apoptosis, producing peptides and antigen that can be presented by antigen-presenting cells to the donor T cells, that we can augment the graft versus tumor effect, so we can start earlier and we resolve the issue of waiting. And the clinical trial is enrolling, and preliminary data suggest a reduction in the relapse rate, but we're waiting for additional follow-up. Also focused on the same type of high-risk patients, but this type are people who have rapidly progressive disease, lymphoma or CLL, that cannot be treated by just allogeneic transplant alone. We give them a sequential autologous transplant followed by allogeneic. And the reason we do that is try to separate the high-dose conditioning from the introduction of the donor cells in order to minimize the interaction between these two factors and causing multiple toxicity. We also focus on people who have persistent or progressive disease after the transplant and trying to control the disease by using some novel agents that can attack the pathway of these diseases, such as protein tyrosine kinase inhibitor, aprotinib, and trying to improve the outcome after transplant and maximize the benefit. In regard to advancing the knowledge, I'm working in a few studies. One of them is trying to address the feasibility and benefit of transplant by looking at patients from diagnosis of a certain cancer like AML, looking how to introduce geriatric assessment into the equation, but also how to use some molecular biomarkers such as microRNA and SNPs in understanding better the biologic link between comorbidities and outcome. And I'll explain a couple of these studies. So even though I showed you that non-myeloablative transplant can result in reasonable outcome in patients who are 60 or above, you can see here from the CIPMTR database that in the first half of last decade, only 5% who were given allo transplant were 60 years or above, and that improved only to 12% in the second half of the decade. So it's really signified that there's some reluctance in referring those patients to the allogeneic transplant. And even though we developed the hematopoietic cell transplant index that can help in risk stratifying patients, but we have to recognize that it was developed really from the group of patients that were already selected by their physicians to be referred to the transplant. It doesn't give us any idea about the larger group of patients from the time of diagnosis that were seen and then selected by their physician whether or not to go forward with a transplant consult. And probably those decisions are based on multiple factors, some of them comorbidities, geriatric assessment, age, socioeconomic, quality of life, what collectively would describe as biologic age, but also on other factors such as the disease features, response to therapy, patient preference, but also the physician perception about chances of cure and ability to tolerate treatment. So I'm working on introducing some of the geriatric assessment and understanding the decision about these patients, things like gait speed that has been shown in the older patient population to nicely stratify patients in regards to their life expectancy, and even can be used in certain cutoffs to determine frail older patients. Other things such as instrumental activities of daily living, which is a more sensitive way to capture physical health other than performance status, shown by some of our colleagues in Chicago that can be combined with comorbidities in a better stratification of survival of older patients. So in cooperation with two great AML scientists, Dr. Fred Applebaum and also Dr. Eli Estee, who I work with him closely on this study, we designed a huge multi-center consortium study that takes patients with AML from the time of diagnosis, focusing on the outcome and decision-making in older medically infirm patients. And as I said, the goal here is to try to develop decision-making information in this observational fashion. And the aims of the study is to try to see what is the rate of referral of older patients to transplant and how that compares to younger patients. And the same for people with and without comorbidities. And most importantly, what are the factors that are being used to decide on this? Is it objective data or more kind of physician bias against older patients? Also, since we will have enough follow-up, we will compare, taking into account the differences between the two groups, how the outcomes look like, allotransplant versus no transplant, the older population. But most importantly, how we disseminate the products of these tests and results into the community practice and help implement them so we can really change the practice in how we evaluate our patients. I was fortunate to be funded by a combined grant from the American Cancer Society and Patient-Centered Outcome Research Institution to do these type of multi-center studies. As I said, we enroll the patient and follow them for about 2 years, collect multiple data at baseline at each of these time points. We collect multiple patient-reported outcomes covering socio-demographic, style, values, preferences. We ask physicians about their perception for their patient. We collect data from the patient about quality of life, performance status, frailty, geriatric assessment, and also satisfaction with the medical care. Here is a list of multiple tools. I will not go through details about this that we use in this observational study. It's a multi-center study, collaboration from 12 different institutions in order to capture the different practice at different sites. And the PCORI funding grant had this idea of having a stakeholder on any project. So we have a large group of stakeholders was represented from patient, caregivers, patient advocates, collaborative group leaders, insurance groups, some representative from the community practice. And they give us a lot of guidance in developing our research, but also in understanding the results and interpreting the results, and give us guidance to make sure we reach our goals. More importantly, in how to come up with ideas where we can disseminate this information as the results come up to be easily accessible to patients as well as community physicians. Lastly, I want to touch on another project I'm working with in collaboration with Dr. Beverly Torok-Stove of the Clinical Research Division and Dr. Manish Tiwari, who left us to Michigan, which is trying to look at some molecular biomarkers that can signify and predict non-relapse mortality and overall mortality after transplant. We were interested specifically in microRNAs, which are those small non-coding RNAs that can negatively control gene expression by blocking translation or promoting mRNA degradation. And why we were interested in microRNAs? Because of all these data that uncover their association with many biological processes that can affect multiple organ dysfunction, but also the idea that a single microRNA could be implicated in more than one single pathologic process. So it seems like a good candidate if we want to look at the association, for example, between comorbidities and a certain or specific outcome after transplant. We started this work a little bit early in 2010, but we were not as fortunate to find funding to proceed with those types of ideas. In the meantime, colleagues in Duke University just published last year a similar kind of concept where they looked at the association between microRNA and the development of acute graft versus host disease in a very sophisticated 3-step analysis, discovery followed by training and a validation. And they could show that from a group of microRNA, 4 of them that are implicated in inflammation, tissue damage, cell proliferation, and tissue repair could give some ideas about risk of development of acute graft versus host disease. But they collected these data after transplant, 2 weeks after the transplant. Our hypothesis was there could be an over or under expression of microRNA before the transplant, similar to the comorbidities, that can give us idea about risk stratification for outcome after transplant. And I'm showing here, you'll hear some preliminary data. What we've done here is divide our patient into a low risk, which are people with no comorbidities who have survived a long time after transplant, and people with high risk who have multiple comorbidities before transplant and did not survive the procedure. And using the nanostring technology from 650 microRNA, 19 came as important. 7 of them was underexpressed in the high-risk group, and another 12 were overexpressed in the high-risk group. Where we're taking this information, we will validate it in a larger data set using different methods, nanostring technology as well as real-time PCR. We're specifically interested in understanding the gene association between these microRNAs and the specific outcome after transplant. I'm also working on association between single nucleotide polymorphism and the mortality risk in collaboration with Dr. John Hansen, who leads the US studies in Fred Hutch, and again, understand the correlation with toxicity. But most importantly, how we can come up with a combined assessment that takes into account molecular biomarkers such as microRNA or SNPs, and takes into account some clinical variables such as geriatric assessment tools or comorbidity indices in order to further improve our way of assessing risk, not only before transplant, but even for treatment of conventional therapy for patients with blood cancer. This is our 79-year-old patient. So I see him in the consult. When you look at his patient-specific factors, the only unfavorable factor was he had a history of melanoma that was resected 30 or 40 years ago that gave him a score of 3. But other than that, he was actually having quite favorable features. His gait speed gave him a life expectancy of 12 years if he didn't have the leukemia. He scored excellent on all types of frailty and geriatric tools, quality of life, excellent social support. He was doing great on his daily activities and had no geriatric syndromes. His disease feature was also favorable. He had normal cytogenetics, favorable molecular markers, no minimal residual disease. So my recommendation was to go forward with a transplant. And he received his transplant as the oldest patient to be given an allogeneic transplant in the University of Washington. He stayed most of his time in the outpatient clinic, and he's now 6 months after his transplant. I want to end up by acknowledging a few people that I didn't mention during my talk. Some of them are study coordinators that are working with me on the observational studies, and also the postdoc fellows. Some of them still working with me, and some have left to a new career. Gary Schock and his team for providing the data, Michelle Bouvier and her team for the non-myeloablative information. Rainer Staub, I wouldn't be here without him. He's my mentor, and I worked closely with him on those studies. I want to also signify the role of Dr. Paul Martin, giving me insightful guidance during all these studies. Dr. Stephanie Lee and Karen Soraya and their expertise in quality of life and patient-reported outcomes. Dr. Jen Hansen, I mentioned earlier, cooperation on the SNPs analysis. Dr. Joachim Dieg and Janine McEwen, again, with their helpful insights. My collaborators at the different institutions and the leadership of the CIPMTR, which were key in disseminating this type of information across all transplant sites. Thank you.
That was great work, great talk. Have you considered or maybe already applied your comorbidity index model to other situations, say elderly patient with aggressive lymphoma who is considering chemotherapy such as R-CHOP?
I specifically have not, but I know that multiple investigators use the same index for people with acute myeloid leukemia receiving conventional treatment and people with MDS receiving supportive care, and it showed quite significant stratification of outcome for conventional therapy. The study that I showed you earlier about the AML, the feasibility of transplant, one of our aims is to come up with a comorbidity index specific for acute myeloid leukemia from diagnosis that can capture early deaths after induction therapy, because we think that models can perform to some extent in different settings, but you can improve if you focus on the outcome of interest. So I think looking at it in lymphoma could be another project or another idea that could produce a lot of information.
Yes. On your comorbidity index, one of the higher predictors of mortality was rheumatologic disease and also a predictor for GVHD, acute GVHD. I wondered, is that only in the setting of active autoimmune disease? Does it relate to the previous treatment and immunosuppressive drugs? Can you expand on what those findings are?
If you're asking me about autoimmune rheumatologic disease, the way we introduce them in the index is we include any patient who have a form of rheumatologic or autoimmune disease that required a specific therapy in their past medical history. We do not segregate based on having active versus non-active disease before transplant, but instead we include anyone that had a significant history of therapy before the transplant. So that's why thinking about looking at certain biomarkers can help signify and refine further those definitions, because it can tell us better which ones already have the active disease that might improve the performance of the model.
Thank you for your work. I'm right here,
Yeah.
sorry. Voice, disembodied voice. I was just wondering how this is used in clinical practice. Do you sit down with the patient? Is this part of the shared decision making, or is this is this one of the ways that you're able to say to people that they're just not good candidates? I'm just curious.
I would tell you it's a work in progress effort, not only here but across the country. So as I said, we now successful in making a lot of sites collect these data. And I know some of the sites, if the physician see a patient and doesn't fill this index, they will receive an email from the medical director that they need to finish this quite quickly because they cannot proceed with a transplant without this information. In Germany, for example, they will not do an unrelated donor search in certain patients if they have high risk of comorbidity because they think it will not be wise to do that if the patient will not benefit from the transplant. Here in my consults, I do it for all patients and I inform them about this information and what does really mean. In our group of discussions, comorbidities is involved in every decision about each patient, whether to proceed transplant versus no transplant, high dose versus non-myeloablative. It's part of our practice. But as these results keep producing, we are learning more as we go forward. Like, for example, we started by comorbidity impact outcome a lot, but now we know that there are other factors. If you add them to comorbidities, it can still stratify each group into better and worse. So we can really continue to refine our models.
Mohamed, that was a lovely talk. I wondered, that one of the things that you found correlated highest with outcomes was disease status when they come to transplant. And what I just wondered was the fact that you didn't see a correlation between age and outcomes. That actually, I mean, that didn't surprise me that if you have bad pulmonary disease or you have bad renal disease, it doesn't matter if you're 30 or if you're 50. But I wondered, I would have thought there are patients disease-specific factors. So MDS presenting in a 20-year-old would biologically behave differently than in a 70-year-old. And that would somehow, I mean, that might inform disease status. But I don't really know how the statistics look in that. You know, in other words, is that lost in the analysis?
I think what I would say here is, since our outcome of interest was non-relapse mortality, that's what we were after, then the role of age was minimized to the least because it doesn't really have any impact once you take into account comorbidities, but it probably, as you said, has still an impact on the final outcome based on disease features. But in these models, we make sure we include all the known factors, like we have a set for diagnosis, for disease status, for cytogenetics, for prior therapy, which sometimes can give also. So I think by taking into account all these factors, sometimes the effective age itself is lost because it's, at the end of the day, it's having more adverse cytogenetics is probably what signify older versus younger patient, etc. So.
Thank you.